Good morning. صباحكم الله بالخير جميعا. دكتور محمد المؤمن consultant nephrology من مستشفى مبارك. I think I met at least maybe half of the group. سارة كانت معنا الشهر اللي فات وغدير حاليا معنا، وأظن في بعد زميلة لكم جاية الشهر الجاي ولا؟ لا بس انتوا ثنتين؟ زين. حياكم الله. اليوم إن شاء الله بنتكلم عن ال CKD. يمكن لاست يير تكلمنا عن ال AKI. هالسنة راح نتكلم عن ال CKD. I will cover يعني in general, what is CKD, diagnostic criteria, what's the etiologies, tests that we should do. The management part, I might skip it and it's very long. Maybe I'll go to maybe managing at the end شوية briefly about the complication of CKD rather than general management. We'll have like a flavor of what kind of management that we are doing. So anyway, lecture راح تكون طويلة بس I will try to do it on time. No disclosures. I will start with a refreshing case. 52-year-old woman presented with nausea and vomiting. Her creatinine was 400. Her past medical history is significant for hypertension and glomerulonephritis of unknown type. On physical exam, her blood pressure was 200 over 100, heart rate is 100, JVP is flat, cardiac exams are remarkable, chest exam is significant for bibasilar crackles. Her hemoglobin was 100 low with normal white cell counts and platelets. Sodium is normal, potassium high, and she has acidosis with bicarb of 17. Her urinalysis showed RBC positive and protein positive. Which of the following parameters are diagnostic for chronic kidney disease? Echogenic kidneys on ultrasound, hypocalcemia, hypertension, hematuria, none of the above. None of the above. Exactly. All are signs of CKD. However, none of these are diagnostic for CKD. Repeat AKI are now recognized to be associated with advanced chronic kidney disease. Recent risk prediction modules have been developed. Important risk factors include female, poor GFR at the time of AKI, age, or all of the above. Diamond here, the easiest answer. All of the above. Okay? And then we'll show why when we go further. So introduction, independent of the initial insult, progression of end to end-stage renal disease is relatively common in chronic nephropathies. Multiple mechanisms like hemodynamic and non-hemodynamic injuries, activity of the primary kidney disease, and the mechanism of natural progression. These all play roles in the progression of kidney disease. So what is chronic kidney disease? How do we define chronic kidney disease? Is the presence of kidney damage or decreased kidney function, which is a GFR of less than 60 for at least 3 months. What do we mean by kidney damage? Albumin creatinine ratio of more than 30 milligrams per gram or more than 30 milligram per millimole, depends on the units. Active urine sediments, mainly persistent hematuria. Kidney transplant is considered a kidney damage. Abnormalities on biopsies or imaging, and electrolytes and other abnormalities due to tubular disorders. So maybe the slide I showed you last year, when we have an initial insult at day 0, we have injury. After 48 hours, we will have the peak of the blood parameters, which is the creatinine that we are doing. After 7 days, we are expecting a recovery. Then they will call this AKI. If the injury persists beyond 7 days, then this would be labeled acute kidney disease or disorder rather than acute kidney injury. If that disorder or disease persists beyond 90 days, then we can label the patient as chronic kidney disease because the chance of recovery is unlikely beyond 90 days.
So what's the 48 hour?
This is the peak of the blood parameters, like the creatinine will rise after 48 hours. That's why for contrast-induced nephropathy, usually we do the creatinine at least after 48 hours to make sure there is no rise in creatinine. Like 48 hours to 7 days. Beyond that, it's unlikely to have a contrast nephropathy. Epidemiology, the prevalence of pre-dialysis CKD, which is stage 1, 2, 3, 4, 5, was estimated to be like 15% of the US population between the ages of 2013 and 2016. And stage 3 was the most prevalent stage. Females has more CKD compared to males. and increases, and the CKD increases with age, as we just mentioned. Age is a risk factor. CKD awareness. Do you think that patients with CKD, they're aware that they have CKD? What's the percentage of those patients? You are so generous. Less than 10% of people were aware that they have CKD, and almost half of them, the awareness was in half of them in stage 4, which is the pre-end stage. You can see how significant is that. This is from the 2018 US data. You can see that almost less than 10% of patients aware that they have CKD at all stages. And stage 4 is the most stage that patients were aware that they have CKD, which reached almost 55%. And the younger, the least aware of their pre-existing CKD. Why is that? Because CKD is almost a silent disease. Uh, it's asymptomatic unless it's reached the advanced stages. Some of the symptoms of CKD that you might find in stage 4 and beyond: poor appetite, insomnia, fatigue, increased urination, hematuria, muscle cramps, nausea, shortness of breath, edema, and dry skin. And so why we are concerned about CKD? ليش احنا وايد هامنا CKD? Because the consequence of CKD goes beyond the kidneys. It's not only the kidney. It can increase all-cause mortality. It can decrease the life expectancy of the patients. It has associated with increased cardiovascular events, increased hospitalization rate. It will progress the patient to end stage and then dialysis or transplant. Impact on multiple other systems and decrease the quality of life of the patients, and definitely increase the cost on patients, caregiver, and the health system. Can see that the cardiovascular events increases with decrease in GFR, the hospitalization rate increases with decrease in GFR, and the mortality as well would increase when the GFR decline. And again, CKD has higher mortality rate than most of the cancers. يمكن الفونت شوية صغير مو واضح. However, only lung cancer has higher mortality compared to CKD. Otherwise, the mortality of CKD goes more than most of the malignancies, and associated with higher cardiovascular disease. You can see the blue bar is the patient with CKD, and the yellow bar is patient without CKD. So it's almost double in any cardiovascular disease. You can see in coronary artery disease is double. In acute MI, it's more than maybe 3 times or 4 times. Heart failure, the same. So in any cardiovascular disease, the patient with CKD has double the risk compared to no CKD patients. And the same for heart failure. The more the advanced the CKD stage, the higher the prevalence of heart failure in patients with CKD. So CKD progression, initially we have an injury, then we'll have an adaptive hyperfiltration, which will lead to decrease in creatinine, eventually CKD progression. The rate of transition from stage 3, 4 to end stage is almost 1.5% per year. However, patients with uncontrolled hypertension, diabetes, and CKD, they will lose almost 12 of ml of GFR per year. When treating these risk factors, this would decrease to almost 4 ml per year. So imagine patients with GFR of 60, and with controlled hypertension and diabetes, after 10 years, his GFR will be 20. However, this with controlled risk factors. If uncontrolled, his GFR will drop by almost 10. So in 4 years, he will reach dialysis. We have a 2 and 5 year kidney failure risk estimate equation that can predict the percentage of patients reaching end stage after 2 years and after 5 years. This is the one, the thing I want to show you on the website. We can do it later. Usually I do it in my CKD clinic in patients who are not really concerned, or يعني اللي مو عارف شنو CKD، او لا دكتور ما فيني شيء، انا I have a patient with GFR of 8 and she's resisting to go to the pre-dialysis clinic. بتقول لا كل شيء بيد الله. We know ونعم بالله. ولكن GFR8 you might come next week in the emergency with volume overload and start emergency dialysis. So I try to show them this risk estimate. It's a very easy, simple equation. You write in Google KFRE, kidney failure risk estimate. There is the 4 variables and the 8 variables. It's very easy. You need only the GFR and the albumin creatinine ratio, age and gender. Then we'll show you like the 2 years risk of dialysis, let's say 10%. The 5 year risk will let's say 15%. فأقول حق المريض أنت بعد سنتين أنت فرصتك أن توصل لمرحلة الغسيل 1 إلى 10. عاد هو ونظرته يشوف هذا وايد ولا شوية. Anything above 15 we know it's significant. Controlled, he will drop by 4 ml per year. Uncontrolled, he will drop by 10 ml of GFR per year. فإذا كان 30 uncontrolled بعد سنتين راح يصير 10. إذا كان 30 وcontrolled بعد سنتين راح يصير 22. فعنده 5 more years to live without dialysis. Okay. So workup, what do we do for CKD? Before I mention the workup, I wanted to show you what's the etiology of CKD so we can understand what can we order for CKD. We know that CKD, almost 60% of cases are due to hypertension and diabetes. 60% من حالات CKD, diabetes and hypertension. This is worldwide, not only Kuwait. Kuwait may be the same or more. And the other 40% is different etiologies like glomerulonephritis or other inherited disorders, AKIs, whatever. Etiologies is divided or classified as the AKI. We have the pre-renal, the renal, and the post-renal. However, here we have more of the chronic conditions rather than acute conditions. Like pre-renal, we have chronic heart failure, chronic cirrhosis. And the renal, we have hypertension, renal vascular disease, TMAs, diabetes, chronic glomerular disease, tubular interstitial nephritis. And the post-renal, we have the obstructive uropathy and retroperitoneal fibrosis. Some terminologies, glomerular filtration rate. What's GFR? It's the sum of filtration rate of all functioning nephrons, defined as the volume of plasma filtered per unit of time, which is ml per minute. It's the production of two main processes, the capillary surface area and permeability, and the net filtration pressure across the glomerulus. Normal GFR is between 120 to 130 ml per minute for women and men respectively. Loss of kidney mass or nephron number is not always associated with the reduction of nephron function. The remaining nephrons adapt by increasing their filtration rate. This is what we called adaptive hyperfiltration, causing FSGS, you remember? When we lose a kidney, let's say واحد تبرع بكليته, the other kidney would adapt the loss by hyperfiltration. So you might not drop the GFR. Some patients, yes, might drop. You saw one patient came with creatinine almost double, and GFR is almost half. But good number of patients would remain with the normal GFR or little drop of GFR after they lost nephron mass. What is measured glomerular filtration rate? The mGFR. We have the estimated GFR, the eGFR, and the measured GFR. So that's administration for exogenous filtration markers like the inulin, the iohexol, iothalamate, and EDTA, followed by serial measurements of blood or urine concentration over time. ليش احنا نقينا those? Because they are freely filtered, 0% reabsorption. So the amount that you get in blood or urine, this is the exact amount that you enter the blood. Most accurate assessment of renal function, impractical for routine use due to cost and complexity, does not provide a quantification of tubular function. Creatinine, it's organic cation, metabolic byproduct of creatine from muscle and dietary meats, not reabsorbed or metabolized by the kidneys, secreted in by organic cation transporters in the proximal convoluted tubules, and increased secretions in late stages of CKD. Few conditions that changes the serum creatinine, either decrease creatinine or increase the creatinine. We know that high GFR can decrease the creatinine, and patients see hyperfiltration, and the higher GFR, they will have a lower creatinine in value in the blood. Decreased generation, like in patients with low muscle mass, limb loss, for example, واحد مسوي amputation, so we'll have a decreased generation of creatinine. Cachectic, cirrhotic, lower extremities of height, increased secretions like hypoalbuminemia and nephrotic syndrome. This would affect the creatinine level. Conditions that increase creatinine when we have a low GFR, we have increased generation by in patients with high muscle mass or the bodybuilders or the upper extremities of height. Increase intake like patient taking creatine or high meat diet. Low secretions. Some medications can cause low secretions like cimetidine, trimethoprim, pyrimethamine, dolutegravir, and الباقي اللي احنا نعرفه يمكن ريتونافير، اميدرون، درونيدرون and ranolazine. Those medications, when you give the patient and he comes next week, you will have rise in creatinine. This is not AKI. This is because of low secretions of creatinine. So that's fine. It's normal. Once you stop the medication, the creatinine will go back to normal. That's why sometimes I don't combine. For example, يمكن انتوا شفتوا معي في العيادة patients اللي يوني I want to start for example either ACE أو خصوصا الجي ان على الاميون suppressants بنعطيهم البروفيلاكسس with Septrin, which is trimethoprim. So I don't give them in combined with, for example, SGLT2 or ACE inhibitor because they will have a rise in creatinine, which I don't know is related to the trimethoprim or the ACE or SGLT2. So I give them كل واحد عقب على الأقل بعد أسبوعين ابدأ الثاني، بعد أسبوعين ابدأ الثالث عشان أشوف. I compare the creatinine. I know which one caused the rise in creatinine. Peritoneal reabsorption in patients with uroperitoneum from bladder rupture and or ureter leak. This will cause increase in creatinine. And cross-reactivity in alkaline picrate methods like acetoacetate and DKA, cefuxetine and fluocytosine. Creatinine clearance. We do the creatinine clearance. This would give us the accurate or the most accurate kidney function. So renal function in CKD. We have the creatinine-based estimate, GFR, which is the eGFR. In a steady state, creatinine level can estimate the GFR by the MDRD or the CKD AP equations. Use the serum creatinine, sex, age, and race to calculate the eGFR. عندنا المختبر automatically يطلع ال eGFR. They have the calculation. يمكن بعد عندكم نفس الشيء. Decreased precision at higher levels of GFR like CKD-AP better than the MDRD, and possibly in advanced age and race other than the white or black. The blood urea nitrogen, BUN, filtered but passively reabsorbed in the proximal tubules, rises more than creatinine in volume depletion or renal hyperperfusion. Not affected by the above conditions, which we mentioned about the conditions affecting the creatinine. The urea will not be affected by these conditions, but overall a less reliable indicator of kidney function. GFR independent high BUN when we have a GI bleed, steroid use, high protein intake, and catabolic state like fever and burns. This will cause high in urea independent of GFR, and GFR independent low BUN with low protein intake, all malnutrition and liver disease. We have the cystatin C based GFR, which we don't use here. It's endogenous protease inhibitor produced by most nucleated cells at stable rate. The cystatin C generation displays less interpersonal variability than the creatinine. It's affected by smoking, thyroid disease, and steroid use. It's alternative. We have alternative CKD AP equation using both cystatin C and creatinine. This performs best. Usually in most the North American hospitals using these two equations, these cystatin C based and the creatinine based to compare the kidney function. Other creatine-based GFR formulas like the kappa, BIS, not shown to outperform the CKD-EP. The limitations, cystatin C assays not as well standardized as for the creatinine. أنا يوميت هني I didn't know that we have it لين وصلني كتاب من المختبر عندنا قالوا we will terminate the test because nobody is using it. Then I realized that we have it. قلت لهم okay thank you خلاص ما راح أقول لكم خلوه عقب ما أدري إيش كثر. ف it's not I think they terminated it at least for the يعني next year. Then we can request again. We have the timed creatinine clearance and the urea clearance. It's measurement of serum creatinine and urea and timed urine creatinine and urea and volume. Practical alternative to measure EGFR in patients whom EGFR is inadequate. Let's say واحد متبرع كليته kidney donor prior chemotherapy. The urea clearance is underestimates the GFR due to the passive reabsorption of urea in the proximal tubules. Creatinine clearance overestimates of GFR sometimes due to the secretions of creatinine in the proximal tubules. Mean of creatinine, urea clearance and creatinine clearance partially adjust for these limitations. Limited by accuracy of urine collection. Over or under collection can lead to extremely inaccurate estimates. You remember this is one of the drawbacks that we talked about, and 24-hour collection is the gold standard for proteinuria, at least, compared to the urine albumin creatinine ratio, protein creatinine ratio, and the dipstick. However, the limitations is the over collection or under collection of patients. يحط زيادة أو يعني يطنش كم collection or اللي هو إنه متعب المريض ما يحبه لكن exactly كل ما أقول حق المريض بسوي لك هالتست يزعل يعني دكتور وتأذيني وكذا. ف I don't do it much unless needed يعني يمكن once every 6 months or every year حق patients اللي I need to have a baseline. However, some patients I do it every 3 months, not every 2 months. Estimated creatinine clearance or the Cockcroft-Gault equations. It's equations 140 minus age multiplied by weight and kg multiplied by 0.48 إذا كانت female divided by 72 by serum creatinine. Less accurate estimation of GFR than the EGFR and should not be used in routine clinical practice for CKD identification and staging. Many drug dosing recommended are based on the creatinine clearance instead of EGFR. ما في much difference. Sometimes we depend on the GFR to dose the medications. And let's say GFR of 30 may be equivalent to creatinine clearance of 40 something. It's an estimate. فإحنا في الكلينيك usually we rely on the GFR. However, most of the drug اللي هو up to date وكذا rely on the creatinine clearance. Yes. And finally, we have the nuclear renogram. It can be used to estimate the relative contribution of each kidney to overall renal function, like patients with prior nephrectomy, for example. This is the roadmap for any patients in clinic, regardless of his kidney state. Let's say he's normal now at the start. He is a normal person. We do screening for CKD risk factors. Then the arrow would go to the right. You can see there is some reversibility. However, mainly it's going to the right. Patients with increased risk will do the CKD risk reduction and screening for CKD. CKD risk reduction, let's say patient is he's on medications and for example he works in the summer, so he's prone to AKI, so we'll try to reduce the risk. However, eventually he will move to the right, so he will have damage, so we need to diagnose and treat, and we treat the comorbid conditions, and we will slow the progression of kidney disease. With time, he will have more of damage and more of decline in GFR. Then we will estimate his progression, we'll treat the complication of CKD, and we'll prepare him for renal replacement therapy. He will move on, he will have kidney failure, then we will start replacement by dialysis and transplant. During all these steps, there will be complications, which eventually all of this will lead to death at the end. So how do we screen for CKD? الخط مو واضح. I apologize. However, we have conditions that increase the CKD risk. We mentioned that. تقدر تكبر. Anyway, we have hypertension, diabetes, cardiovascular disease, AKI or hospitalization, family history of kidney disease, obesity, older age, other high-risk comorbidities, environmental exposure or genetic factors. These all conditions increase the risk of CKD. If the patient has those, yes, then we will screen him. How do we screen? Very two simple tests: creatinine level and urine albumin, serum, urine albumin to creatinine ratio. We did the test. Yes, if he has low GFR less than 60 or urine albumin creatinine ratio of more than 30, then we will start to classify him and risk stratify this patient and know what's his CKD stage. If no, then we'll do a periodic repeated evaluations. This is the stages of CKD. We have stage 1 with GFR of more than 90 plus kidney damage. So if GFR of 120 and the patient has polycystic kidney, he has CKD, stage 1. Stage 2, again, 60 to 89 with kidney damage. Stage 3A, 3B, and 4 and 5, less than 15. And then we have albuminuria of like less than 30, this is stage 1, 30 to 300, stage 2, more than 300, this is stage 3. Sometimes we tend to label the patients, let's say he's stage 3B, A3, which means his GFR between 30 and 45, and he has albuminuria of more than 300. Sometimes you maybe you can see this in any notes or any case, like stage 4, A1, which means GFR 15 to 29, and he has no proteinuria or mild proteinuria. Why is this? Because KDIGO came up with this heat map to guide, let's say, non-nephrologists or primary care physicians when to refer patients to nephrology and taking them seriously. Green means just follow, yellow, be cautious, orange, you might refer the patients here, say grade 3B, like GFR 30 to 45 and minimal proteinuria, or he has massive proteinuria with the normal GFR, you can still follow him, or يعني consider referral. Red and dark red, you have to refer him immediately. Like patients with GFR more than 105, however, he has nephrotic range proteinuria, then you have to refer him to the nephrologist. So why proteinuria is significant? Because the magnitude is the strongest single risk factor in CKD progression and predictor of GFR decline. It increases end-stage renal disease, all-cause and cardiovascular mortality, almost 13% with moderate or microalbuminuria, 13 times, sorry, not 13%, and almost 50 times when we have massive proteinuria. The risk of end-stage and all-cause mortality will increase 50 times when you have massive proteinuria. Therapies that decrease proteinuria generally slow the GFR decline. This is from patients with IgA nephropathy. They estimated their survival from renal failure. The higher the proteinuria, the lower the survival. So patients who had more than 3 grams per day of protein, they have almost 50% survival rate when they after 6 years of disease. So this is how significant is proteinuria. IgA nephropathy patients usually initial presentation either hematuria or incidentally found to have proteinuria. We do a biopsy, we diagnose him with IgA nephropathy. He might not have symptoms. However, he might also present with hypertension because we said that IgA nephropathy is a nephritic kind of disease, not nephrotic. So we control risk factors, you control all of these. Still, despite of that, he has proteinuria. So his chance of survival is almost 50% in 6 years. So this is how significant is proteinuria. one patient كان يجيني العيادة وعندنا الأمور لا ما فيني شيء دكتور ضغطي صار زين أقول له you still يعني you need more يعني you need we need to control your disease أنت عندك proteinuria عندك زلال ما أحس بشيء دكتور كان أراوي هالسلايد قلت له أنت عندك كان عنده يمكن 2 to 3 قلت له أنت يعني your risk after تقريبا 10 years أنت 50% you will be alive after 10 years إذا this proteinuria persist. هني شوية بدأ يستوعب إن لا I have a significant disease. يعني عقب أسبوعين دكتورة أنا أسبوعين ما نمت، أنت قلت لي هذا وقلت لي أحتاج غسيل. ليه؟ لأنك أنت ما تسمع الكلام، يعني لازم نخرك. ف some patients yes I do show them graphs، أراويهم equations على أساس يستوعب إنه yeah I have a significant disease. we said it's asymptomatic. ف patients مرات يطنش لا ما في شيء، نفس هذه الحجية اللي GFR is 8 she refused the pre-dialysis clinic, she refused the pre-transplant clinic. كل ما تجيني العيادة زين دكتور الحمد لله الكرياتين للحين 440 ما صعد. فللحين مو she's not old she's 60. فهذه اللي شوية تعبتني، يعني مو قاعد ما نعرف شو اسوي لها. شلون؟ للحين اي تجيني يمكن next week. للحين رافضة انها تروح هذا. So what's our aim of CKD management? Evaluate etiology and treat reversible causes. However, if not reversible CKD, then the goal should be slow the CKD progression and manage the CKD complications. We have what we call renal-protection medications, which are protecting the kidneys structurally or functionally from damage against harmful effects, which is by controlling and decreasing the rate of CKD progression to advanced disease states and is ESRD. What are these therapies that slow the CKD progression? ACE,
stop smoking, blood pressure, لازم control blood pressure.
good. You mentioned 4 out of ما أدري 20. We have something with the proven benefit. We have prelim evidence. So the proven benefit is the ACE inhibitors, the ARBs, the SGLT2s, the target systolic blood pressure of between 120 to 140, and the diastolic between 80 and 90. We have the selective mineralocorticoid receptor antagonist, and we have the aldosterone receptor antagonists. These are medications with a proven benefit that's slowing the CKD progression. We have a prelim evidence, which is glycemic control in diabetic patients, smoking cessation, treatment of metabolic acidosis, dietary measures, exercise, weight loss in obese, reduction of hyperuricemia, hyperlipidemia, hyperphosphatemia, and albuminuria, folate, vitamin D, acid-base balance, endothelin-1 antagonists, pyrfenidone, and inhibitors of advanced glycation and end production. هذه second part of it. احنا قلنا في عندنا management of CKD هو slowing CKD progression, this is number one, and treating complications if happens. Okay, فالerythropoietin is treating complications, which is anemia. Okay, so treatments to slow the CKD progression يمكن هني we'll go fast on them لأنه وايد ما راح نخلص. قلنا blood pressure control and renin angiotensin aldosterone system inhibitors اللي هم الراس blockades, which is الACE والR. Blood pressure anything below 140 is associated with anything above 130, sorry, associated with increased CKD progression. So our target is less than 130 systolic and less than 80 diastolic. في proteinuric is the same. It's associated with decreased mortality, the blood pressure control. In diabetic, every 10 mercury reduction in blood pressure, whether systolic or diastolic, is associated with better outcome. We give RAS inhibition more than any other hypertensive to decrease CKD progression. This is a comparison between irbesartan and amlodipine. We can see that the irbesartan R was better in all outcomes except for mortality. So mortality was the same. However, all outcome, renal, cardiovascular, and other all-cause end stage was better with the irbesartan compared to amlodipine except for mortality. And the RAS inhibition decrease CKD progression independent of blood pressure effect, even with patients with normal tension. You remember our patient جراح شفتي يمكن آخر عيادة. Anyway, I gave him for proteinuria, I gave him the ACE, he's non-FSGS. I gave him ACE to control proteinuria. يعني عقب شهرين أو 3 أشهر العيادة الجاية مو ماخذ الدواء. قلت له ليش ما أخذته؟ قال لي عليكم السلام. قال لي دكتور قريت عن هالدواء، هذا دواء ضغط وأنا ما فيني ضغط. قلت له أنا مو معطيك إياه حق الضغط، أنا معطيك إياه حق something else. و I did explain to you. فبعدين التزم فيه بالبروتين drop to almost normal. نفس الشيء اقول لهم على الاس جي ال تي 2. لما اعطي المريض اقول له هذا دواء سكر، بس انا مو معطيك اياه للسكر، انت ما فيك سكر، انت مو بري دايبتك، انا قاعد اعطيك اياه حق something else. فهني شويه يقتنعون وياخذونه. ف independent of blood pressure effect, the RAS inhibition showed better renal outcome. Combining ACE and ARB did not decrease CKD progression or mortality. قبل أول ما يمكن أنا بديت توني تريني أسيستنت، أغلب المرضى على إيس مثلا زسترل وديفان، عطى إيس إن آرب إيس إن آرب إيس إن آرب، كان هذا براكتس إيس إن آرب. However, it's not anymore. It showed that did not decrease ال CKD progression or mortality. Multiple studies. It's associated with increase in serious adverse events. can see هني مثلا no change هني losartan and placebo compared to losartan and lisinopril. So ARB and ACE and ARB and placebo. So في الصورة هني الخط مو واضح. البرايمري والsecondary endpoints والmortality were the same in all tested modalities. However, side effects were more in the combined arm. We have هني acute kidney injury, significantly more with the more with the losartan and lisinopril, and hyperkalemia also was more significant with losartan and lisinopril. So hyperkalemia and AKI were more in the combined arm. The only benefit which we don't use it for is there is a proven reduction in blood pressure when combining ACE and ARB, but we tend not to combine them because of the risk factors, because of the side effects. When I start SNR, my patient suffers from hyperkalemia or sudden decline in GFR. KDIGO has like a road map or algorithm what to do in these cases. Maybe you can skip. However, when you start SRR, you have to monitor creatinine and potassium within 2 to 4 weeks. فwhen you start the medication تقول حق المريض تعال لي بعد أسبوعين أو maximum 4 أسابيع عيد التحليل خلني أشوف إذا صار عندك any complications which is AKI or hyperkalemia. Normal kalemia less than 30% decrease in GFR, خلاص we can increase the dose or continue the maximum tolerated dose. Hyperkalemia, we review the other drugs, moderate dietary potassium intake, نقول له قلل potassium intake. Consider diuretics or bicarb to decrease the potassium or potassium binders. إذا صار مع more than 30% decrease in GFR, we review the causes of AKI, make sure إنه ما عنده other cause of AKI, correct the volume depletion if any, and reassess concomitant medications. إذا قاعد ياخذ مثلا diuretics ياخذ NSAIDs هذا شيء ثاني affecting his creatinine. مثلا أعطيناه ACE وأعطيناه trimethoprim for UTI فزادت عنده الكرياتينين. is it true AKI أو ولا هو بس decrease in secretions نفس ما قلنا. Consider renal artery stenosis إذا persistent rise in creatinine. And in these cases, we reduce the dose or stop the ACE or ARB if all the strategies failed to or were ineffective. We have the SGLT2 inhibitors. من اسمها sodium glucose transporter 2, which is in the second part of the tubule, convoluted tubule inhibitors. We have the receptors here. When it's responsible for absorbing glucose and sodium, then glucose will be going to the GLUT receptor and the sodium to the sodium potassium pump. When you block these, then we'll have the glucose and the sodium excreted in the urine. This will decrease the CKD progression for type 2 diabetic, decrease kidney failure and cardiovascular events for non-diabetic as well. I don't need to speak more about the trials, that the positive trials, I would say, that has been done over the last 10 to 15 years on the SGLT2s. هو الترند الحين ال SGLT2 وين ما تروحون any nephrology conference any cardiology conference there should be a talk about any like a new trial for on the SGLT2 يعني هذيل الترايلز على CKD type 2 diabetes this CKD heart, cardiovascular this is heart failure trials and all of these were positive trials all of these showed good benefit from the SGLT2. What's the mechanism for renal protection of the SGLT2? We have the direct and the indirect effect. So indirectly, they improve the glycemic control for diabetics, decrease the insulin level, improve the insulin sensitivity, decrease the weight, decrease blood pressure, and decrease uric acid levels by urine excretions. Direct effect, prevent hyperfiltration, decrease interglomerular pressure, decrease proteinuria. It will prevent glomerular and tuberointerstitial injuries, decrease toxicity of glucose, and decrease inflammation, oxidative stress, and prevent renal hypoxia. Most of the studies on the SGLT2, um, they have a limit of when to start, like GFR, and when to stop if GFR declines. فأغلب الستاديز كانت GFR more than 25 you can start ال SGLT2. في آخر ستادي اللي كانت 2024 in January اللي هي امبا كدني خذوا GFR of 20 هذيل اللي كانوا even lower GFR and despite كانوا طبعا الكات اوف مالهم decrease of اللي هو decline in GFR of more than 10%. كان في almost 3 to 6% of population has a decline GFR more than 30%. and هني اللي هو starting GFR كان less than 30 في 4% less than sorry less than 30 in 4% وفي deterioration to less than 25 happened in 3% of patients. However, despite all this declining in GFR and kidney function, no attenuation of protective effect of the SGLT2 on the kidneys or cardiovascular outcomes. Regardless of the relative change or absolute in GFR level, no overt signals of excess harm. فمعناته أن you gave the SGLT2, the patient has a drop in GFR, drop to below, let's say, 20 or below 25. Regardless of this drop, there was no attenuation of the protective effect of the SGLT2 compared to if there was no drop, and no increased risk or excess harm. So means that you can keep it or continue. However, you have no strong evidence yet. That depends on you and your patient if he agreed to continue or you stop it. Then we have the selective MRA, the finerenone. It's now available in Kuwait. صار له يمكن شهر أو شهرين. We'll skip these. كل الستاديز على الفينيرون وعندنا الالدكتون أو السبايرونلاكتون. Again, it has a good outcome. Other treatments, glycemic control. I'll just move fast because we are running out of time. Strict or intensive diabetic control has better outcome compared to conventional control. What's our target? Depends on your patients. A1C of less than 6.5 or A1C of less than 8. That depends on the severity of CKD. Early stage of CKD, maybe we can target tighter glycemic control. Advanced CKD, we don't need to control him tight because already he's advanced, so there is no much protection that we can provide. If there is macrovascular complications like present or severe, then we'll target 8. Absent or minor, we'll target should be less. Comorbidities, depends on the comorbidities, will determine our target. Life expectancy, patients, elderly, has a uncontrolled comorbid conditions. Bedbound, for example, why I should target tight glycemic control. Hypoglycemic awareness, patients with impaired hypoglycemic awareness, I will not target tight control because he will die from hypoglycemia. Resources for hypoglycemia management, if available, then I can consider tight control. If not, then I would avoid. And propensity of treatment to cause hypoglycemia. Let's say he has other conditions that might push him to hypoglycemia, then I will not treat or push for tight control. Oral bicarb, We know that the acidosis is the low serum bicarb, which is associated as acidosis, independently associated with CKD progression. The lower the bicarb, the higher the progression rate. Bicarbonate trial, it's like there was not a big number, like 134 patients, showed no difference in the complications of the bicarb treatment. Some patients يقول لك لا تعطي صوديوم بايكارب لأن في sodium, which means he will have more of rise in blood pressure and more of edema. However, the bicarbonate trial showed there is no difference between the bicarb and the control in terms of edema, worsening blood pressure and hospitalization. So you can give the sodium bicarb, مو عشان انه هو صوديوم فيو don't give it. Okay. Sometimes في عندنا other bicarbs, but usually we give the sodium bicarb because of there is no evidence of harm. في potassium carbonate, I believe. The oral sodium bicarb, we said the metabolic acidosis in CKD usually onset when the GFR drops below 25. Subsequent adverse effect of acidosis is protein wasting. We have lost muscle mass, we have bone loss, we have CKD progression and mortality increase with acidosis. Our target is more than 22 or 23. We treat with the sodium bicarb. This reduces the CKD progression and improves nutritional status. هذا mechanism of the acidosis. We'll skip that. Hyperlipidemia. Hyperlipidemia, similar to obesity, may be modifiable risk factor to slow CKD progression through pro-inflammatory and pro-fibrotic mechanism. Statins decrease cardiovascular risk in non-dialysis CKD. We have the SHARP trial. This is one of the major protective trials for nephrology. شنو it stands for نسيت. Study for heart and renal protection. Yes. Show the major atherosclerotic events is less with the simvastatin and ezetimibe compared to placebo. Major atherosclerotic events by renal status was better, and the renal outcome was equivocal. The renal outcome was not better. It was almost the same. However, the other outcome, mainly the cardiovascular, were better. Smoking cessation, again, smoking promote the progression of all forms of CKD in a dose-dependent matter. The more the patient smokes, the more the injury will happen. And smoking cessation decrease CKD progression. And this is the mechanism how smoking can affect the kidneys. We'll skip that for the sake of time. Low protein intake. Usually we target between 0.8 grams per kg per day. This might slow the GFR decline in proteinuric CKD, slows proteinuria progression, reduce the occurrence of renal death by almost 30% compared with higher or unrestricted protein. However, the optimal level of protein intake cannot be confirmed by the studies. They reach like 0.8. Excessive protein restriction, like less than 0.6, has no benefit in reducing GFR decline. Is associated with increased risk of death by the MDRD study. So our target would be 0.8 grams per kg per day. Then we'll treat the complications, which I will just go without and then a volume overload. One of the complications, we give diuretics and low sodium intake. We have hypertension. Almost more than 85% of CKD patients have hypertension, and يمكن وايد منهم على multiple medications. Like we can see that almost 50% of them on 4 medications, and out of these 50%, maybe 40% are controlled and 20% not controlled despite being on 4 medications. Proteinuria is a complication of CKD. We already spoke about proteinuria and how significant is proteinuria. Hyperkalemia, it's emergency when the potassium more than 6.5. We treat according to symptoms or ECG changes. We know the treatment of hyperkalemia: calcium gluconate, potassium, and insulin and glucose. Then we give the potassium chelating agents, the new agents. اللي هو عندنا الباترومير اللي هو الفلتازا, I believe, and we have the sodium zirconium, which is the Lokelma. These are the new potassium binders in the market. skip that. قبل كنا نعطي الكيكزاليت أو يمكن اللي هو الكالسيوم بريزونيوم. We avoid لأنه can cause life-threatening hyperkalemia, giving the risk of colonic necrosis. الكيكزاليت associated with increased colonic necrosis, you don't give it for more than 2 weeks continuously. Okay. تعطي على طول كانوا يعطون ايه. فسبيشالي اللي عندهم عندهم مثلا اي بي دي، عندهم diverticulitis, any colon pathology, we tend to avoid giving the cakesalate for more than 2 weeks continuously. We have platelet dysfunction also as a complication of CKD. That would affect the bleeding time, increase the bleeding time due to the uremic toxins, anemia, increased platelets, nitric oxide synthesis. Correct if active bleeding or invasive procedures like kidney biopsy. Treatment نعطيهم دي دي اي في بي. usually الادفانس سي كي دي لما نحط لهم اللاين نفس اليوم يرجع يقول عندي bleeding على الجوز مثلا ولا كذا. We know that he's already advanced, he's uremic, we correct it with the DDAVP that can significant, and we do dialysis. With dialysis, this should control the bleeding. نعطيهم heparin free dialysis, treat anemia if there is, and with resistant bleeding we add cryoprecipitate. Malnutrition caused by uremia related anorexia, decreased intestinal absorption, decreased intestinal digestion and metabolic acidosis. Maintain diet with 30 to 35 kilocalorie per kg per day, and as we said 0.8 to 1 gram per kg of protein. Check dry weight and serum albumin. If decreasing, then we start dialysis. Anemia defined with the hemoglobin less than 13 in males or less than 12 in females, usually normocytic, normochromic, due to the decrease in APO production by the kidneys, erythropoietin. Increased prevalence with CKD progression, like 1% في GFR of 60, almost 70% with GFR of less than 15. Hemoglobin of less than 10 is associated with poor surrogate outcome, which is low quality of life, increase in LVH, اللي هو left ventricular hypertrophy, increase in need for transfusion therapy. واحنا في nephrology we hate giving blood because this will give more antibodies to the patients who want to get transplant. فيعني one of the شغلات اللي احنا we try to avoid giving blood to the patients, although most of our patients are anemic and they come with symptomatic anemia, so we have to give them blood. The lower the GFR, the lower the hemoglobin. Again, the same. Iron, the anemia mostly associated with iron deficiency as well, defined with the TSAT less than 30 and the ferritin less than 100. Iron may increase the hemoglobin, so نعطيهم we target TSAT of less than 30 and ferritin less than 500. في عندنا الأورال elemental iron, we can give a trial, however احنا عادة نعطيهم IV. عندنا الفرنجكت and Furosac. Currently Furosac out of stock, so we are giving the Furinject. ESA, erythropoietin stimulating agents, address correctable causes of anemia prior to ESA. The correctable cause we correct it and then we give the ESA. Consider ESA if the hemoglobin of less than 10 to prevent blood transfusion. The goal is 10 to 11.5 أو 100 to 115. ما نعطي أكثر من كذي. Treating الأنيميا to near normal hemoglobin اللي هو 12 to 13. And pre-dialysis KD with darbepoetin increase the risk of stroke. That's why we don't target higher hemoglobin level. We don't use if malignancy, severe hypertension, or recent stroke. And this is the evidence. We have the COIR trial, CHOIR, showed that the higher the hemoglobin associated with more risk of stroke. Sometimes we have erythropoietin unresponsive or hyperresponsive patients, defined as if no response in 8 weeks, إن ما صار عندنا hemoglobin increase, يعني increase hemoglobin of less than 1 or 2, we consider repeat evaluation for iron deficiency, other potential causes of anemia like folate, vitamin B12 or GI bleed, dialysis inadequacy, the patient على dialysis, maybe he's not receiving adequate dialysis, hyperparathyroidism affecting anemia, aluminum toxicity, underlying inflammation like infection, malignancy, and failed kidney allograft. آخر شيء عندنا ال chronic kidney disease CKD MBD, which is mineral bone disorder. This is a constellation of lab abnormalities like abnormal calcium, phosphate, PTH, vitamin D metabolism, abnormal calcifications, which is vascular or other soft tissue calcifications, and bone disease, which is abnormal bone turnover, mineralization, linear growth, or strength. This all would have a clinical outcome of bone pain, fracture, secondary hyperpara, progression to end stage, cardiovascular event, hospitalization, and mortality. And the PTH level would increase and rise regardless, initial rise of PTH regardless of the calcium and phosphate level. So calcium and phosphate would be normal, however, the PTH will start to rise with a GFR drop around 30 or less. We'll have the PTH rising. Here's the same. طبعا PTH also the vitamin D, the active and inactive vitamin D also would decline. This is the decline in vitamin D and the active vitamin D, and the increase in PTH. Treatment, we check serial phosphate, calcium, and PTH level. We do the DEXA scan, make sure he has no osteoporosis. Treat phosphate to normal with diet and phosphate binders. We have the non-calcium based and the calcium based phosphate binders. If PTH increasing, then we correct hyperphosphatemia. We correct low calcium, we correct low vitamin D. We give calcitrol or vitamin D analogs of severe and worsening high PTH. No vitamin D like nutritional or active. If calcium more than 9.5 اللي هو عندنا تقريبا more than 2.8 or high phosphate, we don't give vitamin D because this will cause worsening of the phosphate and calcium. So in summary and take home message, the pathophysiology of CKD is largely dependent on the primary insult. Robust clinical evidence support RAS inhibition and SGLT2 to help delaying progression in most forms of CKD, especially in those with proteinuria. Slowing CKD progression by treating the underlying cause, use of RAS inhibition, SGLT2, controlling blood pressure, avoiding AKI, and reducing cardiovascular risk are the most important goals for physicians treating patients with CKD. Treating CKD complications when it happens is as important as slowing the CKD progression. هذا عن ال SGLT2, we didn't speak much about it. Anyway, SGLT2 improves the outcome in patients with type 2 diabetes, CKD, and heart failure, and have a favorable safety profile. Prescription rate of SGLT2 is rising but remains low. SGLT2 inhibitors represent the greatest advancement in slowing CKD progression in decades and should be prescribed whenever indicated and tolerated. And new therapies for CKD and its disease-modifying complications are being developed. So thank you very much, and if you have any questions, more than happy to answer. الله يعافيكم. الله يعافيكم.